let's continue with the session 2. And on behalf of the Translational Research Group in Liver Diseases of RITS, CONICET, and Universidad Austral, I would like to thank the extraordinary panel of speakers for being here. The next presentation will be given by Professor Becerra. Dr. Jorge Becerra is Professor of Pediatrics and Director of the Division of Gastroenterology, Hepatology and Nutrition at Cincinnati Children's Hospital Medical Center. He holds the William and Rebecca Balistrieri Chair of Pediatric Hepatology and is the Medical Director of the Liver Care Center. He will present a paper entitled Intrinsic and External Regulators of Bile Duct Epithelial Development and Survival. Please, Dr. Becerra, it's your time.
Thank you very much for the kind introduction. Can you see my slides?
Yes.
So I will present briefly 3 concepts today. And there is the survival of the cholangiocyte represented by this cell, can be influenced by soluble factors secreted from neighboring cells. They can have abnormal intrinsic biological processes that may make the cells or produce a leaky epithelium. And they may also be influenced by metabolites that come from intestinal microbiome. Focusing first on the first model, in which innate lymphoid cells type 2, a type of immune cell, can secrete cytokines that influence proliferation of cholangiocytes. For these studies, we use the mouse model of biliary atresia. In this mouse model, administration of rotavirus leads to the development of acholic stools at 7 days of age of a neonatal bulb C mouse. And when a transverse section of the extrahepatic bile duct shows the occlusion of the duct lumen by inflammatory plug. In this model, this plug evolves to fibrosis. We'll summarize the results of studies assessing this inflammatory response following rotavirus infection. We found that after rotavirus infection, the cholangiocytes secrete cytokines that lead to the attraction of neutrophils and macrophages, and perhaps this may also be occurring when the bile duct is exposed to toxins such as biliatrisone. Once this inflammatory process starts, there is a further expansion by activation of dendritic cells and recruitment of NK cells, CD8 T cells that produce cytokines that further expand this inflammatory response. In trying to prevent this inflammatory response that is largely Th1 or type 1 pro-inflammatory response, we used a Th2 molecule known as interleukin-33 to try to blunt this response. But what we saw was that the administration of interleukin-33 to neonatal mice led to an increase in the size of the extrahepatic bile duct. On your left here, you have a excised gallbladder and cystic duct connected with the extrahepatic bile duct of a neonatal mouse. This is after 1 day and 1 dose of interleukin-33, 2 doses, 3 doses, and you can see the gallbladder does not increase in size, but the bile duct does. After 4 days and after 7 days, the extrahepatic bile duct is almost as big as a loop of the duodenum. We've shown that what happens is the administration of interleukin-33 activate these innate lymphoid cells type 2 or ILC2s, which produce interleukin-13, a type 2 cytokine. Interleukin-13 has two properties. In the cholangiocytes, it induces mitosis and leads to a proliferation of cells, perhaps as an attempt to repair the initial injury to the epithelium of the extrahepatic bile duct. Notably, the same biological process inside the liver actually activates stellate cells and produce the secretion of extracellular matrix, and in the mouse, hepatic fibrosis. We are now studying how does the activation of the interleukin-33 receptor, known as ST2, can lead to this divergence of processes. So we know then that at the final stage, there is an attempt of the immune system to actually repair the biliary epithelium, but unfortunately, this attempt is not effective enough. The second concept is one that provides additional support to Dr. Rebecca Wells' studies that show that there is an abnormal or a delayed intercellular junction development in the early neonatal epithelium of extrahepatic bile ducts. For these studies, we used cholangiocyte organoids or biliary organoids from biopsies of babies with biliary atresia and from normal controls. In this approach, small fragments of liver biopsies are used to generate biliary spheroids. You can see here that when we grow the small fragments of tissue, the spheroid begins to emerge and they grow over time. We are able to passage these spheroids on your left from a normal liver biopsy, on your right from a liver biopsy of a baby with neonatal cholestasis not due to biliary atresia, and in the middle, organoids from liver biopsies from babies with biliary atresia. When we section these organoids, we see the nice epithelial lining with the nucleus closer to the base. Generally a same organization is seen in the disease control, but in biliary atresia, this columnar epithelial, if you will, has much shorter cytoplasm and a much greater nuclear to cytoplasmic ratio. We stained these spheroids with markers to look at cell polarity, and we can see in the normal, F-actin is expressed primarily in the surface of the epithelium looking to the lumen, and beta-actin in the base and between the two cells. The same pattern is seen in the epithelium or in these cells of the disease control, but in biliary atresia, this is quite aberrant with misplacement of this staining. Staining for ZO1, like Dr. Wells did in her study, we saw a normal pattern in the normal control and in disease control, but really very sporadic staining in the cells from biliary atresia organoids from babies with biliary atresia, right? And we can see here on the electron microscopy in the normals that you can easily identify these intercellular junctions, which become much more difficult to find if the cholangiocyte organoids come from biliary atresia biopsies. In this cartoon, I summarize the details of the studies. So here we generate organoids from normals. We stain for the cilium, and we can see that the cilium is organized towards the lumen of these cells, and that when they are incubated with are rhodamine 1, 2, 3. There is some absorption or some uptake, but not very much. When we do the same using liver biopsies from babies with biliary atresia, we can see that the cilium is present, but they may be largely displaced either outside or sometimes right in between these epithelial cells. And when they're incubated with R123, there's a much greater uptake, suggesting that the organoids coming from livers of biliary atresia, they have an increased permeability, perhaps, at least in part, secondary to this delayed or abnormal ZO1 expression. Now, what is, I think, interesting and needs to be pursued further is that when we treated these organoids with a combination of FGF and EGF, we actually noticed that we were able to flip the cilium back into the towards the lumen in most of the cells and decrease the permeability and improved ZO1 expression. So perhaps this implies that the defect in the epithelium is not necessarily a fixed defect, but one that represents a delayed development and could serve as therapeutic targets. Let's now go to the third one, which is the survival or the influence of external factors, in this case, metabolites from the microbiome, to improve the survival of cholangiocytes. This study came from an initial observation that JG, a postdoctoral fellow in our laboratory, reported that by feeding Bactrim to the mother, challenge of the neonatal pups with rotavirus actually led to a decreased incidence of experimental biliary atresia. And he showed that using 16S to sequence the microbiome of the neonatal mice, those that had whose mothers received Bactrim in red had an increased enrichment of actinobacteria and anaerococcus, and these bacterial populations are predicted to produce butyrate. So with this finding, he pursued a simple experiment in which he fed the pregnant mouse with water or butyrate throughout pregnancy. And then when the pups were born, he infected the pups with rotavirus in both groups. And what he saw was that pups that came from mothers that were treated, that received butyrate during pregnancy, had increased survival and much intact epithelium of the extrahepatic bile duct and less inflammation of the liver, compared to the obstruction of bile duct and inflammation of the liver if the mice came from mothers that received only water during pregnancy. So we performed a series of studies, including the injection of butyrate into the pups that protect but did not follow the same mechanisms that we saw when the butyrate was fed to the mother. And then we studied the stools of the mice and babies with microbiome to look at their microbial population, studied fecal metabolomics, and then assess whether these metabolites directly influence cholangiocytes. Summarization showing just a couple of data and then a picture for the results. In this cladogram of the microbiome from the mice, you see here that if the mice came from mothers that were fed butyrate, they were resistant to biliary atresia in green. And you can see that the microbiome of these mice are enriched with Bacteroidetes, Clostridia, and Firmicutes. If we then we did metagenomics of a stool samples of about 100 babies with biliary atresia and about normal, 30 from normal age-matched controls, we found that in green, that represent normal age-matched control feces, there was also an enrichment of bacteroidetes, similar to the mice, and Clostridium, similar to the mice, and an enrichment of proteobacteria and other known pathogens in the babies that had biliary atresia or in the mice that had biliary atresia. We went back to the mice and obtained a stool supernated, did metabolomics and found that there is a high enrichment of hypoxanthine and glutamate. We then studied and then we administered this to the mice to see which one would be effective. Instead of showing the results, let me summarize them here. So our approach was studying the fecal in the mice, studying the stools of the mice with and without biliary atresia. We assessed their immune cell and noticed that if they came from a mother treated with butyrate, they had decreased immune cell activation, high production of glutamine and hypoxanthine, and an enrichment in the stool microbiota of bacteroidetes and Clostridia. In babies with biliary atresia, we had, so in the normals of normal controls was like the babies that had, in the mice that had been fed with butyrate, with increased bacteroidetes. So in biliary atresia was low. Decreased proteobacteria in biliary atresia was high. And normals or increased production of glutamine in biliary atresia was low. Injection of glutamine to the pups led to a decreased inflammation, decreased epithelial injury, and decreased bile duct obstruction with increased survival of the mice. When we injected inosine, a relative of hypoxanthine, we did not see this effect. At the cellular level, we showed that the presence of glutamine renders cholangiocytes resistant to the killing of NK cells, and further noticed that this protective effect of glutamine to cholangiocytes was due to an enrichment of the glutathione prevalence or abundance in the cells and a decreased oxidative stress. So now we know that products of innate lymphoid cells such as interleukin-33 can be a survival factor to cholangiocytes, that in patients with biliary atresia, there's a defect, an intracellular junction that may lead to increased permeability, and that bacterial metabolites, specifically glutamine being potentially one of them, can render cholangiocytes resistant to the killing factor of inflammatory cells. So thank you very much, and these are supporters of our studies in the laboratory. Thank you.
Thank you very much, Dr. Becerra, for this fantastic presentation. We have a few minutes for questions from the audience. Waiting for the questions, I would like to ask you about the organoids. And in order to increase the epithelial maturation, which of the factors you mentioned can be modified from the therapeutic point of view to promote or to increase cell maturation?
So I think that these are very early observations, and perhaps any of the activators of the EGF or EGF receptor ligands, probably together with FGF, because we did not see, if we incubate the cells with each one of them separately, they do not promote this further, what we call a maturation of cholangiocytes. So probably both of them But to be of potential application in the clinic, we would want to detect biliary atresia early on, perhaps before, at early stages before the entire bile duct is obstructed, to try to repopulate these cells. Or perhaps after Kasai, whether they may serve to further mature the intrahepatic cholangiocyte stage of perhaps delayed development. So a lot to be done before we can apply, potentially try some preclinical studies.
Thank you. And Dr. Wells is asking here if you can speculate on the role of the abnormally localized cilia.
Yes, we think that the abnormal localization of cilia is probably one of the factors that showing that there may be a delayed development of the cell. It could also be that it represents an initial ciliopathy in response to a biological effect of this delayed development. We have additional studies showing that if we treat, if we get any, if we derive cholangiocyte organoid from a normal liver, which has normal epithelium with normal cilia, if we injure cholangiocytes, the cilia begins to be misplaced, mislocalized. So maybe the cilia malpositioning is part of a intrinsic ciliopathy response to an injury.
Okay. There is another question from the audience. How could you differentiate epithelial to mesenchymal transition process from an intrinsic injured bile duct?
That is a great question. Actually, if we look at these these cells in organoids from normal and from biliary atresia, we already see that in organoids from biliary atresia, they already have evidence of VMT in the cells themselves when compared to the normal controls. So maybe this delayed maturation of the cell keeps a phenotype that is easy to undergo epithelial to mesenchymal transition. So this may be part of the intrinsic pathogenic mechanism of why the baby develops fibrosis so fast, in addition to the factors listed by Dr. Wells on her talk.
Thank you. And other question here, have you, from Dr. Bayo, have you studied the activation level of the hedgehog pathway in the organoids?
So yes, not completely, but the initial markers of that hedgehog pathway is actually activated in biliary atresia when compared to the normal biliary organoids. And as you probably know, this has been assessed in the tissues of biliary atresia and published before by Dr. Anna May-Dio and her collaborators.
Another question from Spain, Dr. José María Argemi. Since ILC2 are activated upon virus infections in mice and humans, do you think ILC2 enrichment could be influenced by the model using a rotavirus?
There is actually very little activation of innate lymphoid cells and very little production of interleukin-33 following rotavirus infection. This is in contrast, if you look at the human biopsies from a patient with biliary atresia, there is a subset of the patients that have increased production of IL-33 and its receptor. So whether this expression by innate lymphoid cells is due to a rotavirus infection or another stimulation it looks like at least in human, this process is very activated, but may represent an if not ineffective attempt of the innate immune cells to repair an epithelium that tries but is unable to effectively repopulate and restore intact epithelium.
Thank you very much, Dr. Becerra.